Good evening, everyone. Myself, Dr. Mitesh Shashikant Sompura. I am a cardiac physiotherapist. I am working in UNMICRC Institute of Cardiology and Research Center since last 14 years. Today, in continuous physiotherapy education, my topic is hypertension and exercise. So let's start with hypertension. The global prevalence for hypertension is very high. Hypertension is a major cause of cardiovascular disease and deaths worldwide, especially in low and middle income companies. In 2019, around 1.28 billion adults aged between 30 and 79 are estimated to be affected by hypertension worldwide, with the prevalence rate of 32% in women's and 34% in men's. Now, if we'll talk about situation in India, in 2015, a systematic review and meta-analysis of the prevalence of hypertension done, and which comes with the output of prevalence rate of 29.8%. So hypertension is responsible for 57% of all stroke deaths and 24% of all coronary heart disease in India. Hypertension ranked as the third most important risk factor for attributable burden of disease in South Asia. World Health Organization rates hypertension as one of the most important causes of premature death worldwide. Now, if we will see the deep in the scenario of India, we can see that 33% of urban Indians are hypertensive, and among that 42% urban Indians are aware of their hypertensive status. And among that 42%, 38% of urban Indians are being treated for hypertension. And among that 1/5 of urban Indian hypertensive population have their blood pressure under control. And if we'll see on the rural side, there is a 25% rural Indians are hypertensive, 25% rural Indians are aware of their hypertensive status, and among that 25%, only 25% rural Indians are being treated for hypertension. And from this 25%, only 1/5 of rural Indian hypertensive population have their blood pressure under control. Now the definitions. Following definition and stages is based upon the appropriate blood pressure measurement technique, and it is suggested in 2017 by American College of Cardiology and American Heart Association. If systolic blood pressure is less than 120 mmHg and diastolic blood pressure is less than 80 mmHg, then it is the normal range. If systolic blood pressure between 120 to 129 mmHg and diastolic blood pressure is less than 80 mmHg, then it is an elevated blood pressure. Now, if the systolic blood pressure is between 130 mm and 139 mmHg and diastolic pressure is between 80 to 89 mmHg, then it is a stage 1 hypertension. Now the stage 2, if the systolic blood pressure is more than 140 mmHg and diastolic blood pressure more than 80 mmHg, then it is a stage 2 hypertension. Now in some cases, isolated systolic hypertension and isolated diastolic hypertension is also found. In isolated systolic hypertension, systolic blood pressure is more than 130 mmHg, whereas the diastolic blood pressure is less than 80 mmHg. In isolated diastolic blood pressure, the systolic blood pressure is less than 130 mmHg and the diastolic pressure is more than 80 mmHg. Now, here the European guidance has some contrast with the American guidance. The European Society of Cardiology and European Society of Hypertension, the International Society of Hypertension, as well as the National Institute of Healthcare Excellence defines hypertension using office-based blood pressure as a systolic pressure more than 140 mmHg or diastolic blood pressure more than 90 mmHg. So here the Europeans guidelines suggest that the blood pressure should be measured not only in the clinical setup but also at the patient's home, and also blood pressure should be measured throughout his daily activity as well as his night. So basically a 24-hour blood pressure measuring concept given by the European Society, and based on that the diagnosis of the hypertension now requires integration of home or ambulatory blood pressure, whereas routine measurements made in the clinical setting should be used primarily for the detection purpose. Ambulatory blood pressure monitoring is a method to measure your blood pressure on a continuous basis for 24 hours. Your blood pressure measures even as you sleep. So, the result can be confirm a high blood pressure diagnosis and guide treatment. This ambulatory blood pressure monitoring also used to identify how the change is in your blood pressure throughout the daily activities. Usually, systolic blood pressure falls by 10 to 20% in during sleep. So, also this device can help that how your hypertension medication is working effectively. It can also be used to rule out some unusual blood pressure types like white coat hypertension, mask hypertension, nocturnal hypertension. So this one is very important nowadays to rule out or to make a confirmed diagnosis of hypertension. Now here we will compare the American guidelines and the European guidelines which suggest for the blood pressure. Here in American guideline, if the clinical blood pressure is more than 130 by 80 mmHg, then it is suggestive of hypertension. If home blood pressure monitoring is more than 130 by 80 mmHg, then it is also suggested as hypertension. About the ambulatory blood pressure monitoring, here we can see the 24-hour mean ambulatory blood pressure monitoring. If it is more than 125 by 75 mmHg, then according to American guidelines, it is a hypertensive state. In contrast with American guideline, European guidelines state that at a clinical setup, if the blood pressure is more than 140 by 90 mmHg, then it will be suggestive of hypertensive. With compare of at home, it is more than 135 by 85 mmHg of blood pressure. About the ambulatory blood pressure monitoring, European guidelines suggest if it is more than 130 by 80 for the 24 hours, then it will be diagnosed as a hypertension. In this slide, these are the corresponding values where you can compare or you can make a reference. Like if clinic 120 by 80 should be a normal, at home 120 by 80 normal, daytime ambulatory blood pressure 120 by 80 is normal, nighttime ambulatory blood pressure 100 by 65 it is a normal, and the 24-hour ambulatory blood pressure should be 115 by 75 mmHg. So according to the higher range like 130 by 80, 140 by 90 and 160 by 100, what will be the reference value for home and ambulatory blood pressure monitoring? Now we are moving towards the types of hypertension. The first one is the primary hypertension. It is also called as essential or idiopathic hypertension. 90 to 95% of cases of hypertension is constituted with primary hypertension. The etiology is multifactorial. A number of interacting homeostatic forces are involved. Either a gradual onset or a prolonged course, or an abrupt onset and a short dramatic course that proves rapidly fatal without swift intervention is also known as malignant or accelerated hypertension. Now the secondary hypertension. Secondary hypertension results from an identifiable cause. A variety of specific disease states or problems are responsible. 5 to 10% of hypertension population has secondary hypertension. Now the other forms of hypertension, borderline hypertension, intermediate elevation of blood pressure interspread with normal reading still carry an increased risk of developing cardiovascular disease. Benign hypertension is a term used to describe uncomplicated hypertension, usually for long duration and mild to moderate severity. It may be primary or secondary. Malignant hypertension is a syndrome of markedly elevated blood pressure, in which the diastolic blood pressure usually goes high, over 140 mmHg, and it is associated with papilledema and if this malignant hypertension is untreated, it can convert into accelerated hypertension. Accelerated hypertension is a syndrome of markedly elevated blood pressure with retinal hemorrhage and exudates, presumably develops into malignant hypertension if not well managed. Now, white coat hypertension. White coat hypertension defined as blood pressure that is constantly elevated by office readings but does not meet diagnostic criteria for hypertension based upon out of office readings. So here the patient's blood pressure could be elevated in office areas, but at clinical area and out of office area the blood pressure will be normal. So this kind of hypertension also we need to rule out after the 3 months of lifestyle modification, and if patient is not on anti-hypertensive medication, then it should be need to evaluate white coat hypertension. Mask hypertension. Mask hypertension defined as a blood pressure that is constantly elevated by out of office measurements but does not meet the criteria for hypertension based upon office reading. Here the scenario is quite contrast. In this case, the out of office blood pressure is constantly elevated, and also if the patient is not on anti-hypertensive medication and persistently this type of scenario present for at least 3 months, then it is a need to evaluate for mask hypertension. Now we are moving towards etiology. Primary hypertension, poorly understood but is most likely the result of numerous genetic and environmental factors that have multiple compounding effects on cardiovascular and kidney structures and functions. Now the risk factors are age, obesity, family history, race, reduced nephron numbers, high sodium diet, excessive alcohol consumption, physical inactivity, insufficient sleep, and social determinants. Now the secondary or contributing causes for hypertension. Prescription or over-counter medications. Such medications will cause hypertension. So what are that medications? That are the oral contraceptives, especially with the estrogens, non-steroidal anti-inflammatory drugs when it will be in a chronic use, antidepressants, corticosteroids, decongestants, some weight loss medications, sodium containing antacids, erythropoietin drugs, cytosporin drugs, some stimulants like methylphenidate, amphetamine, atypical antipsychotic drugs, angiogenesis inhibitors. And if you call about the systematic involvement, then primary kidney disease. Primary kidney disease, in most of the kidney disease there will be a retention of sodium, and because of that blood volume overload it causes the hypertension. Second is renovascular hypertension. In this the blood, the vessels which carries the blood to the kidney will be narrowed, and due to that the hypertension occurs. Third one is the obstructive sleep apnea. Obstructive sleep apnea is a phase where a person having a apneic phase during his sleep. So there will be a 10 to 16 second of apnea during his sleep, and because of that hypoxic phase there will be release of some toxins and also the structural changes which causes the hypertension. Now the phenochromocystoma, Cushing syndromes, endocrine disorders, coarctation of aorta. Because of coarctation there will be increased blood pressure in the upper extremity, and that hypertension if not controlled then it will lead many complications. Then primary aldosteronism. So these are the secondary or contributing causes for hypertension. Now the risk factors which are non-modifiable and modifiable. Age, gender, family history, ethnicity, previously any transient ischemic attack or stroke, These are the non-modifiable risk factors. And what are the modifiable risk factors? Are obesity, salt intake. We should restrict the salt intake, correction of any potassium deficiency, then saturated fats, alcohol, dietary fiber, smoking, stress, physical activity, and socio-economic status. So these are the modifiable risk factor. We can do work for this modifiable risk factor, and also we can overcome with the prevention of the hypertension. Now moving towards pathophysiology. Primary hypertension, arterial blood pressure is a product of cardiac output and total peripheral resistance. Cardiac output is determined by stroke volume and heart rate. Control of peripheral vascular resistance is maintained by autonomic nervous system and circulating hormones. Therefore, any factor producing an alteration in peripheral vascular resistance, heart rate, or stroke volume affects the systematic arterial blood pressure. 4 control system plays a major role. First one is the atrial baroreceptor system. Baroreceptors are the mechanoreceptors which will sense the mean arterial blood pressure, and according to that there will be a sympathetic and parasympathetic activity which increase the blood pressure or decrease the blood pressure. Second one is the regulation of body fluid volume. Third one is the renin-angiotensin system. It is also called RAS, renin-angiotensin-aldosterone system. Last one is the vascular autoregulation. Now, mechanisms involved in secondary hypertension includes increased secretion of catecholamines, increased release of renin, expansion of sodium and blood volumes like in Cushing syndromes. Now, the diagnostic, how to diagnose hypertension. As I said previously, according to American and European guideline, and there are some other laboratory investigation which are required to fulfill the diagnosis. The first one is the electrolytes and serum creatinine. Second one is fasting glucose, urine analysis, complete blood count, thyroid stimulating hormones, lipid profile, ECG, urine albumin to creatinine ratio, and also in some cases echocardiography. Now the treatment part. Now treatment is based on pharmacological therapy and non-pharmacological therapy. In pharmacological therapy, there are various group of drugs with their various actions. It will control the hypertension. The first one is diuretic. In that, loop diuretics like furosemide, potassium sparing diuretics like aldactone, which will preserve the potassium. Second category is vasodilators like hydralazine, which will vasodilate the peripheral veins, so it will reduce the peripheral vascular resistance. Next is adrenergic inhibiting agents, in that beta blocker like propanol and metoprolol, alpha adrenergic inhibitors like prazosin, hydrochloride. Fourth category is calcium channel blocking agents like nifedipine, verapamil, hydrochloride. And the last one is angiotensin converting enzyme inhibitors like captopril and enalapril. Now moving towards non-pharmacologic therapy. First one is a dietary salt restriction. If the appropriate amount of salt is taken, then it will be very helpful to our body for controlling hypertension. If excessive of salt will directly leads to volume overload, and as a consequence of hypertension occurs. Next one is a potassium supplementation. If any deficiency of potassium is also directly related to volume overload, and if any deficiency should be corrected. Third one is weight loss. If a person reduce weight by 5 to 10 kg, then there will be a downgrade in systolic and diastolic blood pressure. Fourth one is a DASH diet, dietary approach to stop hypertension. In this diet is focus on more vegetables and fruits. Fifth one is exercise. Exercise is also proven to control hypertension and I will discuss about exercise in the next slides. Then last one is the restriction to alcohol and smoking. Now moving toward exercise. Introduction. The health benefit of regular exercise are well established. Regular exercise is recommended for many purposes, including blood pressure lowering. Other health benefits include a reduced risk of cardiovascular disease, diabetes, lipid disorders, breast and colon cancer, weight gain, frailty and bone disease. So now what type of exercise could be done in hypertension? So there are three recommendations. First one is the dynamic exercise, isometric exercise and aerobic versus anaerobic exercise. Dynamic exercise, also termed isotonic, refers to the regular purposeful movement of joints and large muscle groups. Isometric exercise involves the static contraction of muscles without joint movement. Aerobic versus anaerobic describes the availability of oxygen for energy production during contraction and most often reflects the relative intensity of exercise. Now, health benefits of regular physical exercise. It will lower risk of all cause mortality, lower risk of cardiovascular disease mortality, lower risk of cardiovascular disease, lower risk of hypertension, lower risk of type 2 diabetes, lower risk of adverse blood lipid profile, lower risk of cancer of the bladder, breast, colon, endometrium, esophagus, kidney, lung and stomach. It will also improve cognition, reduce risk of dementia, improve quality of life, reduce anxiety, reduce risk of depression, improve sleep, slow or reduce weight gain, weight loss, particularly when combined with reduced calorie intake, prevention of weight regain following initial weight loss, lower risk of fall related injury, lower risk of fall, improve physical function, improve bone health. So there are various health benefits of regular physical activities or exercise. In this slide you can see that higher the physical activity duration, and more you do the exercise, vigorous or moderate exercise, there will be a less chance or there will be a reduction in mortality rate. The combination of vigorous and moderate exercise will have the maximum benefit. In this slide you can see with the more moderate and vigorous intensity physical activity, there will be a reduction in premature deaths. Now everyone can do exercise, but what are the excluding criteria? First one is the angina pectoris or a feature of cardiac ischemia without chest discomfort, either on rest or with exertion. Dyspnea on exertion or at rest, paroxysmal nocturnal dyspnea and or orthopnea, syncope or pre-syncope, arrhythmia or palpitation and the cardiac murmurs. If this kind of symptoms present, then it is not suggested to do any kind of exercise. First consult your doctor, and if they suggest, then only the exercise could be performed, and for that also a separate diagnostic test should be done, and if patient is qualified or approved taken from the healthcare professional, then only a patient can involve in exercise program. Now all activities typically involves a combination of aerobic, dynamic resistance and isometric resistance exercise. For each type of exercise, key features All related to dose are duration, intensity and frequency. So we can decide the type of exercise, that are the aerobic, dynamic and isometric resistance, but how we will perform that one, what will be the duration, what will be the intensity and what will be the frequency. So amount of exercise measured as fit protocol, that is frequency, intensity, type and time or the duration. The first one is the frequency, the number of sessions per week. So if you are doing 30 minutes or 45 minutes every day or 5 days in a week, so 5 is your frequency. Then intensity compared with rest expressed in metabolic equivalent as the METs, that I will explain in the next slides. Type, as I previously said, aerobic, dynamic resistance or isometric. And last one is duration, minute per session. So here if you are doing 30 minutes 5 times a week, then your 30 minutes is a duration, or that is a time, and 5 times a week is your frequency. Now, how to determine exercise intensity? It is an important factor in developing cardiovascular performance and fitness. So there are 3 methods to measure intensity. The first one is training heart rate or target heart rate, second is METs, and third one is rate of perceived exertion. Now here in this slide we will see that how we could measure the intensity. The first one is the target heart rate or training heart rate, is based on the linear relationship between heart rate and oxygen consumption. Target heart rate is measured by a standard formula, that is the Karvonen formula. As you can see in this slide, the formula is target heart rate equal to maximum heart rate minus resting heart rate multiplied with the percentage of heart rate reserve in addition with resting heart rate. So for example, if a person with 20 years of age, his maximum heart rate will be 220 minus 20 equal to 200, and here we are taking resting heart rate at 60, and percentage of heart rate reserve I am using here 60%, and the resting heart rate again the 60. So the sum of all these numbers, it is 144. So the target heart rate at the 60% of heart rate reserve is 144. So this is our intensity for the activities. Now the next is MET. MET estimates exercise intensity by comparing the VO2 during an activity at rest. At rest, VO2 is approximately 3.5 ml per kg body weight per minute. So that is measured as 1 MET. So as the activity increase, as the stress increase on the body, the oxygen consumption will be increased and the METs amount will be increased. So in the next few slides I will show you some activities with different METs. Now the next one and last one is rate of perceived exertion, are scales based on an individual's perception of how hard they are exercising, and it is measured by a standard box scale. Here you can see this is the standard chart of rate of perceived exertions which is calculated by box scale. In this scale you can see a number from 6 to 20 and based on that the scale is given. So if the scale is 6, so the exertion is very light. For example, the activity like reading newspaper, watching television, so that is the at that time your exertion level will be 6. That activity is very light to you. So 6 to 8 it is very light. Then 9 it represent very light. So for example, if you are tying a shoelace or wearing shoes, so that activity represent 9 number, or it's a very light activity. So 9 to 10 very light. Now 11 to 12 fairly light. In this activity you require some light effort like shopping through grocery store. So those activities require some effort but not a moderate effort. Now next 13 to 14 is somewhat hard. In this type of activity you required moderate exertion, but your heart rate will increase and your respiratory rate will slightly increase. The activity is like walking or brisk walking, so this will comes under 13 to 14. Then next is 15 to 16, where you feel exertion hard. So activities like swimming, cycling, this activity required moderate effort, and your heart rate will increase, and your respiratory rate will also increase, but it will be sustainable. You can sustain with that. Next one is 17 to 18, that represent very hard. So here the activities which requires vigorous effort, okay, like running. If you run for 10 minutes, 20 minutes, but still if you are able to continue with that activity, so that one is represented by very hard. And the last one from 90 to 20, it is very hard. It is like a burst of activity that you are unable to sustain. So like finishing a race or activity, by doing that you are fully exhausted and you are unable to do further any activity. So that level of exertion is represented by very hard activity. Now how much exercise you should do when you are hypertensive? So there is a universal recommendation given by American College of Sports Medicine for the individuals with hypertension, how much moderate intensity a person should engage. So there are three types of exercise is recommended. First one is the aerobic exercise, second is resistance exercise, and third one is flexibility exercise. So how much time we should do and what will be the frequency? For aerobic exercise, it is recommended that 30 minutes, 5 to 7 days per week. For resistance exercise, 30 minutes, 2 to 3 days every week, and flexibility exercise, 10 to 15 minutes every 2 to 3 days a week. So these are the standard recommendation given by the society. Now the type of exercise. First one is aerobic exercise. As you can see in the picture, that the various type of aerobic exercise like walking, cycling, jogging, playing, doing yogas. So now what is aerobic exercise? Is most extensively studied form of exercise. Definition: the regular and purposeful movement of large muscle groups in moderate and or vigorous activity that places stress on the cardiovascular system. Examples like brisk walking, jogging, dancing, bicycling, swimming, using certain exercise equipments like elliptical machine. Now, more intense exercise required more mats. As I said previously, if you do more vigorous exercise, the oxygen requirements, the oxygen consumption of your body will be raised, and that will reflect the mates. So now more intense exercise require more mats. If you are walking 3 miles per hour, so that will be a 3.5 mats. Okay, if you are jogging at 14 minutes per mile, then it will be a 6 mats. So now how the aerobic activity express? The total amount of aerobic activity expressed as exercise volume, and it will be measured by average mats multiplied by total number of minutes per week. For example, if you are walking at 3 miles per hour for 30 minutes for 5 days, so your total minutes are 150 minutes per week, okay, and the mats are 3.5. So the exercise volume is average mats 3.5 into 150 equal to 525 mats per week. So if you are doing 30 minutes walking 5 times a week, then your mats consumption will be 525 mats per week. So that is your intensity, and the person is estimated to reach 500 to 1000 mats minutes per week. Here are the some examples for the activities and the consumption of energy represent in METs. Like if you are walking 3 mile per hour, it will with 3 to 5 grade uphills with the elevation, so it will 5.3 METs. Biking 9 to 10 meter per hour, 5 to 5.8 METs. Stationary bicycle 6.8 METs. Then biking 30 meter per hour, 8 METs. 50 meter per hour, 10 METs. Swimming 50 yards per minute, 8.3 METs. Running 6 mile per hour, 9.8 METs. So according to activity, the METs requirement will be increased, and this will increase the cardiovascular efficiency and cardiovascular work. Exercise intensity for aerobic activity may be categorized as follows: light, moderate, vigorous and near maximal. For light, heart rate reserve or VO2 30 to 40%, 2 to 3 METs activities, and rate of passive exertion should be 9 to 11. In moderate, heart rate reserve or VO2 should be 14 to 60%, 4 to 6 METs, and rate of passive exertion should be 12 to 13. In vigorous activity, heart rate reserve or VO2 60 to 90%, and 8 to 12 METs activity, and rate of passive exertion should be 14 to 17. And in near maximal, the heart rate reserve or VO2 should be more than 90%, and activities will be required 40 to 20 METs, and rate of passive exertion is 18 to 20. Now, several meta-analysis and systematic reviews of trials suggest that aerobic exercise significantly lowered resting clinic systolic or diastolic blood pressure by 3.2 or 2.0 mmHg, and daytime ambulatory blood pressure monitoring by 3.3 and 3.5 mmHg respectively. Aerobic training also affects beneficial effect on lipoprotein, decreases in low density lipoproteins, increases in high density lipoproteins, body composition, increase in aerobic capacity, improves homeostatic factors associated with thrombosis, and animal studies suggest beneficial changes in insulin sensitivity, autogenic nervous system function. Now, the dynamic resistance exercise. Dynamic resistance exercise characterized by effort that is purposeful against an opposing force, accompanied by purposeful movement of joints and large muscle groups. Examples like weightlifting, circuit training, push-ups, biceps curls. Meta-analysis including 25 trials that examine the effect of resistance training on blood pressure suggests mean reduction in systolic and diastolic blood pressure in 2.7 and 2.9 mmHg respectively. Now, in this picture you can see the difference between isometric and isotonic. In the first image, it is an isometric exercise where we can see that a high level of tension without the muscle fiber changing length and without a change in joint angle. And in isotonic contraction, first one is concentric phase and second one is eccentric phase. In concentric phase, muscle fiber shortens as they produce adequate torque to overcome the force of gravity and joint angles become smaller. In the second eccentric phase, muscles lengthen as the fiber continue to exert force but at a torque slightly less than the force of gravity as joint angle grows larger. So in isometric, the muscle fibers length will be same and there will be no change in the joint angle, but in isotonic the weight will be the same and muscle fiber will be shortened and also the joint angle will be reduced and lengthened. Now, there are some types of examples for the dynamic resistance exercise. You can see in the picture the dumbbell thruster, overhead press, kettlebell swing, weight step up, farmer carry, goblet squat. So this exercise will perform with particular weight, and in this exercise, as I said previously, The weight will be same during the entire exercise, but the muscle length and angle will be changed. Now, isometric resistance exercise characterized by sustained contraction of muscles with no change in the length of the involved muscle group and no change in joint angle. Maintaining a constant position such as sitting against wall without chair or maintaining a plank position. Some isometric resistance exercise may involve equipment such as hand grips or weighted resistance machines. Meta-analysis of studies suggest beneficial effect on blood pressure. So these are the example of isometric resistance exercise. The first picture on the left side is a plank, and the second picture on the right side is a sitting without help of chair, sitting at a wall. So in this particular activities, the isometric resistance will required. Now, exercise recommendation to lower blood pressure from professional committees and organization. You can see that 6 professional committees has given the recommendation for exercises based on the FIT principle: frequency, intensity, time and types. In that ACSM also given the recommendation which I have previously shown in the slide. Now, what are the benefits? So, the evidence rating for ACSM is category A and category B. For American Heart Association is a class 1 level of evidence, and European Society also has rated with class 1 level of evidence. So these are the standards and rating given by various kind of researches, and after the conclusion, after the result and the beneficial effect over blood pressure, this societies has recommended such frequency, intensity, type and duration for the population of hypertension to reduce their blood pressure. So what are the effects on blood pressure? So you can see that in ACSM's recommendation, blood pressure reduction is 5 to 7% among those with hypertension, and in European Society it is 2 to 3 overall. 5 to 7 among those with hypertension are benefited with reduction in hypertension. So a person suffering from hypertension should perform at least 150 minutes of aerobic exercise every week and 75 minutes of resisted exercise every week to control their hypertension. This is the recommendation given by the authentic and very scientific proven committees. So do whatever kind of exercise you can prefer in aerobics, like walking, jogging, cycling, dancing, swimming, playing any particular sports. It will be helped to control your hypertension. And lastly, your body can do it. It's time to convince your mind. So if you are suffering from hypertension and if you are also on a medication, you can do such exercise which I have described in this presentation to control your hypertension, and it will benefit you a lot. So it is just about our mind preparation. If we prepare our mind, then definitely we can do it and we can control our blood pressure. These are the reference I have taken from. So lastly, thank you very much for listening me. I also want to thank my organization and my head of department to give me such opportunity to present a presentation on hypertension and exercise. Thank you very much.